Hi, and welcome back to the NCS podcast current series. This is Lauren Koffman. I'm a neurointensivist at Temple University in Philadelphia. And today I'd like to welcome onto the podcast authors from a recent Currents article, Neurorecovery, Understanding the Landscape of Post-NeuroICU Clinics. So we're going to be welcoming Dr. Matt Jaffa. He is the co-founder and associate director of the Neurorecovery Clinic at Hartford Healthcare, and Dr. Julia Carlson, who's the director of the Neurorecovery Clinic at UNC Chapel Hill. So thank you both for joining today.
Thanks for having us.
Thank you for having us.
So before we get into the details of what you guys do with your clinics, and your kind of research project about it, could you tell me a little bit about how you came interested in this area of research?
So for me, I in residency started meeting with survivors of long-term ICU and hospital stays. For example, there was a young gentleman I'll never forget who was in an accident from a motorcycle injury when he was 18. And he was coming back 10 years later and really suffering from complex regional pain syndrome. And he had just been bumped around from doctor to doctor, and no one really knew what to do with him. And that's where I saw that there was this opening for patients with these complex care needs. And I started to become interested in post ICU care.
For me, very similarly, I had the great fortune of training at University of Maryland, and Melissa Moda there has a neurorecovery clinic, and so I got to start seeing some patients who were in their recovery stages. But I think there were two keys for me that kind of led me down this path of interest. One, which was I'm very interested in palliative care and what are the outcomes for our patients and how do we adjust care models as we move forward. And then secondarily, we also often say to families, you can try to see what recovery is going to look like in the next couple of months or years. But then I never really figured out who was going to see them at that moment in time, a couple of months or a year later. And so it just seemed a natural fit for a neurointensivist to fill in that spot.
Great. So it sounds like you both had kind of unique opportunities to get exposure to this concept in your training. So I'm just curious, when you were making the transition from training to your career, did you know that this was going to be part of your career path? And did you pick your kind of jobs based on the desire to build these programs?
Yeah, for me, it was definitely a part of my search. I discussed it with every institution that I looked at, that I wanted this to be a part of my career. I recognized that it was probably not going to be a large financial opportunity for the hospital that I was going to, but it was something that was really important to me and I felt was going to be important to the patients that we were caring for. And so it was a part of my search for sure.
Yeah, absolutely. I had worked really closely with David Lynn from Massachusetts General Hospital and his neurorecovery clinic and program. And so he and I had had a lot of prep discussions coming out of fellowship 2 years ago. And it was something I discussed at every interview about me coming and doing this, because one, I thought it was the right thing to do. Two, because I thought it would also build for a research program.
Awesome. So now that we know a little bit about why you're motivated to do this, can you each talk a little bit more about what your individual clinic is like? Like, how did you set it up? How do you kind of funnel patients in, and who's staffing the clinic?
Yes. So I see anybody who has had a 1 week or longer ICU stay at UNC Chapel Hill. There are some exceptions to that because of the other programs that I'm surrounded by. So Dr. Cleo Rubinos has a post-acute symptomatic seizure or PASS clinic. So those patients get funneled there. We also have other things that sometimes come into the ICU, like an ALS patient who's going to go to ALS clinic. We have a large oncology population and they follow up with oncology. But I see anybody else who's stayed in the ICU for longer than 1 week. And the goal of that is to be able to really see the patients who would benefit from this kind of follow-up care. And like Dr. Jaffa, who also may have time-limited trials of care. And so it threads the needle to try to find those patients who will benefit.
Yeah, I think most of the patients that I see are funneled through my general interest in the long-term follow-up of patients who have had tough decisions to make about what their goals of care are. So for the most part, I'm seeing the very ill patients who the families were conflicted as to what the right decision for the patient would be in terms of trachs and pegs and prolonged durations of restorative care. But I also see anyone in our ICU. Mostly I try to focus on patients that I at least touched on their care while they were in the ICU, so I can provide them with some context when we're meeting of what happened when they were in the ICU. But they have to have come through my ICU, and then I just ask them whether or not they want to, or their families would like an additional visit with me when they're through. And I set it up early on that this is a 1 to 2 visit kind of relationship with the patient and their family.
And are you each the only person in your group that kind of staffs this clinic?
My group, it's me and the director of our neurocritical care department who also joins. He is Augusto Parra. He's been intensivist for many years and has always had an outpatient practice as a component of his critical care. So far, I've been unsuccessful in convincing all of my partners to join me, though everyone has said they've at least one or more patients that they would like to follow up. And so I've offered them spots in my clinic to take those patients on.
I'm the primary person in the neuro recovery part of the clinic. And then again, Dr. Rubinos also has overlap patients. So she does some of the similar things, but also has a different subset of patients that she follows up as well. And then I also I'm open to having trainees. So both fellows and residents from UNC Chapel Hill join me. And then my clinic is once per month.
How often is yours, Matt?
I also have one clinic day a month. For now, we're hopeful that we would increase that over time, but as an intensivist, it probably will never get beyond, 1 to 3 days a month, I think.
And it sounds like, you're both kind of pulling people towards the clinic that you've personally taken care of. But is there any kind of, I guess, protocolized way for patients to be referred to you within your institution when you're not involved in their care?
Yeah, and I'm sure that Julia would say the same thing, but as we were developing the clinic, we had many meetings with stakeholders throughout the system. So the neurosurgeons, the stroke neurologists, the PM&R folks. My wife happens to be a primary care doctor in our system. And so I have funneled a lot of people through that if they were in the neuro ICU at Hartford Hospital, anyone can get in touch with me, and then I'll review the case to decide if it's someone that I think we can provide some additional assistance for in the clinic. And so a lot of the APPs and the residents know that I'm doing this, and they will say, hey, there's this case that, the patient's been here for 5 weeks and the family's really struggling, or we think that this patient is someone who's going to fall through the cracks of our system as it's laid out right now. We'd like for them to come to your clinic. And as long as they seem appropriate for the clinic and we can support them, then we bring them into our clinic.
Matt, you alluded to the fact that sometimes when people have had prolonged or complex hospital stays, they get referred to you. So in my mind, I would never, put 2 and 2 together that that's a potential patient population that needs this. So could you just tell us a little bit about that? Like, I think Julie alluded to it as like a trial of therapy, because that's a newer concept that some of our listeners might not be familiar with.
Yeah, I guess it is a relatively newer concept of this trials of limited restorative care, or time limited trials of restorative care. And oftentimes we think about that when patients are in the ICU and whether or not we should continue pressors for a certain period of time, antibiotics for a certain period of time. The most natural time point that we think about in the neuro ICU would be the time to transition to tracheostomy and peg tube. And so unfortunately, that for many of our patients, as most listeners probably know, is a really early time point within the recovery or the natural disease process for most of the patients that we're seeing. And so for many families, they are coming up against a time limit where they feel they need more time to make a decision about whether or not the continued recovery of the person is going to match their goals. And so what I try to offer is this concept that even though we're making one big decision early on in their stay, that they don't need to consider this to be the last decision that they make that affects how the person's quality of life is going to be, and whether or not their goals of care are going to match the care that they're actually receiving in the future. And so I try to think about different ways that when we get beyond the first couple of weeks or months, that if a person is improving, that's great. We try and offer them different ways to get other resources that they might need. But if they're not improving and the family says, it's been 9 months, we really have not seen them improve in their degree of consciousness, and this is not what we were hoping for our loved one, then we start to talk about what are the ways that we get off of this train if we need to, and what those might look like. And that's different from state to state. Obviously, there's a lot of controversial topics around MAID or medical aid in dying. But there are other simpler things like, can we get someone onto hospice when they are at this point in time? Or should we move towards do not hospitalize, or just change their code status from full code CPR to do not resuscitate at that point in time if that matches better with their care.
And I think there's a real challenge that I didn't understand until I got into this arena, that our patients and their families experience, where they know in their mind that there's a time limited trial of care, but at that 3-month, 6-month, 12-month mark, the recovery they were hoping to see hasn't occurred. But who is actually following that trial up may not be somebody who is comfortable with neuroprognostication, may not understand what happened during that ICU stay. And the nuances of making, as Matt was saying, of navigating that change can go better when it's with somebody that is familiar both with what happened in their original injury, but also what's happening now, and can bridge that gap. And it's also post-ICU clinics are set up to do this in a way that SNF physicians may not be able to, primary care physicians may not be able to. A patient may not have been connected to palliative care at their time of discharge, and now 3 to 6 months later, that's a more appropriate consult to be involved in their care.
Yeah, just to follow that up briefly, there is also a lot to do with when people are making these types of decisions early on in their stay, they may not be ready to make those decisions. Claire Kreutzfeld wrote a really great paper on this a couple of months ago, I think, or maybe a year ago, about when people are able to make decisions. And oftentimes it's not in that early phase. It is much further down the road that they're finally able to make a decision that would be different than what they initially thought. And so we want to make sure that we have given them an opportunity when they're ready to make different decisions.
And do you each have your like a standardized approach as to how you evaluate these patients? Like, are there specific metrics that you use, or is it really individualized to like the patient, whatever the pathology was for their brain injury?
Matt and I both use a very similar format. He was one of my mentors when I started to develop my clinic. So I think I can speak for both of us on this. So we both start out with a review of the ICU course. This is sometimes the first time this patient actually understands or has an opportunity to ask questions about what happened in the ICU. So we'll do things like talk about their imaging and show them their brain injury and answer their questions. And then we both focus on talking about what are the current symptoms and what has happened next. Have they gone back to the hospital? What was that like? Where are they now with their therapies? Are they home? Are they in an assisted living? What medical equipment do they have? And we often both review things like ADLs, IADLs, sleep, depression, sexual dysfunction, mobility, and then we both collect things like where they are in terms of their cerebral performance category, their MRS, so that some of those more functional outcomes as well.
That sounds pretty extensive. How long are each of these clinic visits allotted?
My clinic visits are allotted 1 hour. However, I will say that I go way over depending on the patient. And that has been both a joy and a true curse when I'm on service and having to run back to the ICU to take care of things. But it's also been really wonderful because many of the visits I've been able to extend, and their extension has been walking the patient or wheeling them, whatever it may be, back to the ICU to see the nurses and the rest of the team after the visit's over.
I also have an hour long for each visit.
And do you have any other ancillary services or consultant services available as like a multidisciplinary, or is that more you determine what the needs are and then we'll set that up for the patients and their families?
We started at Hartford with that as the concept. And for me, the concept of how to build a neurorecovery clinic came out of the ALS clinic world, which is what I had done some research in before medical school. And so I had always seen this as a clinic with multiple different physicians. So the neurointensivist, the neurosurgeon, if the IR was involved. I've even toyed with trying to convince PCPs to join us for the many patients that land in our ICU who don't have a PCP. So this might be an introductory visit. PT, OT, neuropsych. Unfortunately, as I mentioned earlier, this is a very in the red type of clinic financially. And so we've had to scale back. We started off with a neuropsychologist that was involved in our clinic. We started off when we were engaging stakeholders, bringing PT, OT, and other therapies into the clinic, but we've brought ourselves back to the point where right now, if I think there is need for neuropsychology beforehand, if I've been tracking or stayed in touch with the family and think it's necessary before, I'll set up a referral for that beforehand. Or once I've had the visit, I will subsequently get them involved with our neuropsychologists. In terms of PTOT, one of the issues that we often run into is that many of our patients are already in a facility where they're getting that. And so there are billing issues and overlap that can't be that has difficulty in being traversed right now. But hopefully, as we go forward and continue to build, we'll learn more about how we can best institute some of that multidisciplinary model.
Yeah, that's the dream, is to build it to be multidisciplinary. But right now it's just a one-stop shop with me.
Julia, I would actually love to hear your experience with any interest from the residents and fellows. You mentioned that it's available to them. So it sounds like it's more of an elective. It's not part of their training, but it's an option for them to participate.
Yes. So usually when I've had trainees come, it's because they want to see somebody specifically, and they also want to see what I add to the conversation instead of, say, their normal stroke follow-up or their usual epilepsy follow-up, and to see those types of issues that we are able to get into and address more specifically. And so for fellows, that's been where they've been really involved in a patient's care and then been able to see that patient really did get better and how valuable that is, and is a part of my feedback mechanism to our neurosciences intensive care unit. And then for residents, where they can become so frustrated and it can be really hard in those long hours and days where they're only seeing inpatients, that they actually get to, again, see somebody who went through something with such a severe acute brain injury that they not only survived, but that they're home and that they're thriving.
Awesome. That's great. So now that we've heard a little bit about your experiences, why don't we chat about the project, the research project you're doing, which is in a survey form, and just tell us a little bit about like what the aims were, and then we might be able to hear about some of the results, I hope.
Yeah, so started off trying to sort out who out there is doing this type of clinic, right? Most people will tell you they became a neurointensivist because they hated being in the clinic and there was zero chance they were ever going back. I'd argue that Julia and I are probably very similar in that we did not love general neurology clinic, but we did love taking care of patients who had been really sick in the ICU when they came into our clinics as residents and fellows. And when you just look up neuro recovery clinic, there are a couple of websites that come up. UCSF has had a website up. The MGH group has a website up, and now there's a really beautiful website from University of Pennsylvania. But there's not a lot out there for who is doing this, and we just wanted to know what the landscape actually looked like. So we painstakingly went through every single state and emailed the either the head or at least someone in the neuro ICU at every single hospital in the country that we could find an email for, and sent them a survey that just asked some basic details about what their interests were, if they had a clinic that they could participate in, and whether or not they participate in a clinic, if they were what they could see as the benefits to participating in a clinic or why they actually ran their clinics.
And we had 200 people approximately respond to the survey. Most of them were attending physicians, about 132. And the majority were at academic medical centers, over 200 of the 218 participants. Of those patients, 69 participants had available clinics, but we don't think that actually represents 69 separate clinics because it was distributed via mass email to the same center often. So there might have been more than one survey respondent responding about the same institution.
There's almost certainly multiple people from each. So everyone at my institution, I'm hoping, filled out the survey, and there are only two of us out of five who do it. So there are more people filling it up. But that was also, to us, really important because we wanted to understand, why are people not doing it? Some people said it was because they're just not interested in doing the clinic after they've been in the ICU all week, and others who said, I didn't even know it was available to me to do. And so that was a really important part of this as well.
But the vast majority of people, about 43%, indicated that they actually would love to participate in a post-ICU neuro recovery clinic. And 39% said they would want to maybe do it, but they have other pressing duties that they are responsible for in their job. And then the survey participants also indicated that they thought that the importance of post-neuro ICU recovery clinics was to reassess expected versus actual outcomes, about 20%. Another 20% also felt that identifying or mitigating gaps in care was one of the benefits of these clinics. And then the last one that people were most commonly identified was that recognizing challenges faced by our families in the ICU could be addressed in this form.
I mean, even with some duplicates, I think 69 is a lot higher than I would have ever guessed for that amount of respondents. And then I'm also surprised by the percentage of people that would be willing to consider doing it. So I would love to hear from both of you how you would try and convince someone that is in the other proportion of group that is uninterested in doing it, why you think, or how you would convince them to consider staffing a neuro recovery clinic.
I think part of that answer comes from why neuro post ICU and in particular post neuro ICU recovery clinics matter, and a lot of it is not just what we give to the patients and families that are coming to see us, but rather, more importantly, what we're giving back to the ICU when we see them. So we're evaluating, as Julia mentioned, the expected versus actual outcome. That's really important when you're prognosticating on all of these varying injuries that come into our facilities, and we say we know what this is going to look like in 9 months. And for many disease processes, we know that that's just not correct, right? We know that when you give people with ICHs more time, or cardiac arrest, more time to recover, we see significantly better outcomes than would otherwise have been predicted based on models or people's experience. And that has a lot to do with early withdrawal of life-sustaining therapies, but also self-fulfilling prophecies. And so I think that that's one really important thing that we are able to bring back is, hey, I saw this patient who was locked in and is now walking, and they're doing great. Or I saw this patient who's doing really well clinically right now, but they have significant depression and anxiety related to the care that they received while they were in the ICU. They felt like they were, they were hallucinating the entire time they were there, and they're really struggling with that now. And it's important for us to bring that back to the ICU to improve the care that we're giving when they're in the acute phase of their illnesses.
I would add to that, we know that survivorship for critical care illness is increasing, and it has been since the late 1980s. And we have to think past, ICU mortality or 30-day hospital mortality into what is the lived experience of our patients and their families. And a clinic can be very versatile to, again, match the needs of your local institution or city or state. And so it can think about things such as, recognition of those chronic symptoms or diseases that relate back to ICU care. It can evaluate quality of life. It can connect patients to resources. It can also provide family support and guidance, because this is a totally new way that these patients are often living from their pre-injury baseline. And again, it can provide reprognostication and palliative care and determining future goals of care, as Matt was talking about. And this has been written about a lot in the post-medical ICU community through the Society of Critical Care Medicine and their Thrive, or the CAIRO initiative, which stands for the Critical and Acute Illness Recovery Organization.
Even if you're just interested in research, this is an outstanding opportunity to actually follow up your patients, as Julia said, much beyond the typical time points that we're looking at. How is a person functioning? What's their MRS at 3 months or 9 months? But really looking further down the road and being able to say, yeah, at 2 years, this patient is doing phenomenally well. It turns out everyone at 1 year is doing okay, and then the subsequent secondary injuries start to compile, and they're starting to tread water at that point.
Great. So now you've convinced so many listeners that they want to move into this field. So what advice do you have to either build a clinic or to get involved with someone that's running it? Like, how should people work towards this if it's something they're interested in?
I think many of us who have done this, Matt, myself, the folks at UCSF and at MGH, are all resources. I'll volunteer, all of us. I would also say that the first thing to do is to meet with your stakeholders. When I've talked with other people who've set their own clinics up, the first thing everybody says is you need to talk to your co-neurologists. You need to speak to your physiatrists who are already working in this, who may already be working in this space. You want to talk to and partner with your neurosurgeons. And again, think very carefully about what are the specific goals of the clinic that you are hoping to achieve. Is it based on a specific disease course? Is it a type of patient? Is there a gap that you can fill in, and go from there to build it?
We've also developed a neuro recovery clinic consortium over the last couple of months. And so people are more than welcome to email myself or Julia. My email is matthew.jaffa, J-A-F like Frank, F like Frank A, at hhchealth.org. Or you can find me on Twitter. And we'll be happy to get you involved in those meetings. And right now, most of the people in our consortium don't actually have clinics. They're interested in pursuing it as a possible different avenue of their careers. And so they're just learning about what it is that some of us who are doing it how we've come to this point and what we see as the next steps. And so it's a really great place that if you are interested and would like to learn more, you can meet all the people from UCSF, MGH, Maryland, now UNC and Hartford, to talk more about neurorecovery.
Do you have any final words of wisdom you'd like to share with our listeners?
Think that the most important thing I can say is that all of what we learn in training about critical illness, and what happens down the road, it's so important to remain exceedingly humble about what our knowledge for each individual patient is, and the best way that we can try to gain a little additional confidence in the decisions that we're helping families to make is to see them down the road in clinics, as one of the main avenues.
This is a challenging area to be in, but it's a really worthwhile pursuit to see our survivors back.
Well, thank you both for joining. We really appreciate it. We'll make sure we include a link to the article in the show notes. And to check out this or other Currents content, head to currents.neurocriticalcare.org. And as a reminder, NCS offers free CME for select podcasts. Listen via the NCS Learning Center and complete a short survey to receive your credits. Otherwise, you can access the NCS podcast wherever you get your pods. And don't forget to add us to your favorites so you never miss an episode.